You already had them up.
All right, you guys. What I'm going to talk about now is our stroke assessments that we do. We've talked a little bit about that already. With the first one being our FAST assessment. The other one is going to be our Cincinnati pre-hospital stroke scale. And then the very infrequently used is the Los Angeles pre-hospital stroke scale. Out of all three of these, I'd say the one that gets used the most is going to be the Cincinnati one. And this really is just the FAST exam. So we already know that with FAST, the letters spell out facial droop, arm drift, slurred speech, and then time. With our Cincinnati stroke scale, this is actually going to be more of a physical assessment. You're doing your grips. You're having them. Can you grip my fingers? Can you push against my hands? You're finding those pulls and pushes. What are we looking for when we do that? Deficit. I'm just looking for deficit, so they have any weakness on one side or the other. So we're going to incorporate that. So grips, pulls, and pushes. We're going to incorporate that into our facial droop, arm drift, and our speech. How do we really assess somebody's slurred speech? You just listen to them? What are we saying?
You just have them repeat something.
Right. Have them repeat a common phrase or a phrase that everybody kind of knows and listen to it. Does it sound normal? Probably the easiest one that you'll see a lot is, you can't teach old dogs new tricks. Yeah, don't do that, kids. Right? Sure. It should be something. It should be something that you can normally say without slurring. If you start getting any of those woodchuck or Sally Souls seashells, that's going to cause some issues in of itself. So this is going to be your Cincinnati pre-hospital stroke scale. Very simple. It's very easy to do. It should only take you 30 to 60 seconds, really, to make a quick assessment on that. So now the Los Angeles pre-hospital stroke scale is a little bit more involved. And really what they're looking at is they're looking at specific criteria that is a higher probability that they are having a stroke. If I have anything that's positive here, facial droop, arm drift, and or speech, that's going to be a positive stroke scale assessment, and we're going to be thinking about taking these individuals to a stroke center. With the Los Angeles scale, you have to have all of these, and this is going to give you something like an 80% probability that the patient's probably having a stroke. The first one is they have to be greater than 45 years old. No history of seizures. Right? Why is this an issue? Right. Maybe they're having these symptoms because they just had a seizure. So, no history of seizures. The signs and symptoms of this particular stroke, from your facial droop, arm drift, and slurred speech, is within the last 24 hours. They haven't recently been hospitalized. They have a blood glucose level between 60 and 400. Why is blood glucose an issue? I know Drew was just asking about this when we went to break.
It could be altered. Yeah, they could be altered.
Right? Maybe that's the reason that they're having these symptoms that look like stroke symptoms. Maybe they're hypoglycemic, right? Or they're severely DKA because their blood glucose level is so high. So that's something that we need to do on any patient that's having stroke symptoms or is altered. You always get a blood glucose level. Yes, sir.
Would it make sense maybe if your patient's altered, go through your AEIOU tips and then decide if you want to go under stroke scale, or just go through?
Well, you're going to be doing that in your initial assessment. It's kind of one of those things that you're just going to do as you go through it. You're going to be ruling all those things out. And generally, what's is blood glucose take a long time to get? You can just delegate that to somebody else on your team. Have them do it while you're going through and asking questions. You're doing grips, pulls, and pushes. You're figuring out all of this stuff as we go along. The other thing, they should not have any unilateral, and this is going to be our facial group, any grip weakness, arm weakness, or motor asymmetries. So what is motor asymmetry?
The ability to control one-third movement on one side.
Yeah, so again, it comes down to that one-sided weakness or paralysis. So they have to have all of these in order for them to be positive for the Los Angeles Pre-Hospital Stroke Scale. This generally comes with some sort of a stroke checklist. And it's a very involved assessment. So when we have something that's involved, generally, what does that take a lot of? It takes a lot of time, right? When maybe we should just load and go this patient, treat and route, right? I'll get to that checklist here in a minute. Here we go. Yeah, so you have to have all of these to be positive. Like I said, when I looked this up, they said it's something like 78 to 82% likely that they are having a stroke. So it takes a lot of time. Yeah, I have that checklist. I don't remember what I did with it. All right. So in general, though, what are we going to do to treat these? We've kind of hit on this several times already. But what's our treatment and management of any patient that's having a stroke?
Rapid
Titrate
transport,
O2.
titrate 94, 99.
Exactly. So we're going to O2 titrate 94 to 99%. That may just be a cannula. That may mean that we need to put them on an on-rebreather. But that's the O2 stats that we're looking at. Try to do a 30-degree elevation of the head if possible. Here we go.
Suctioning, watch the seizures.
Yeah, honestly, you're going to have suction ready. We're going to be prepared for possible seizures. All right, so this checklist, they have to be greater than 8 years old. No recent history of a hemorrhagic stroke. Why do you think this is in the checklist? What are we really doing here? Right, this is actually a TPA checklist, because that's going to be the definitive treatment for our occlusive or our ischemic strokes. No recent history of any kind of head trauma. They don't have a history of uncontrolled hypertension. And the reason we have that on there is this could be a hemorrhagic stroke. And so that's not anybody that we're going to want to give TPA to. What's an AV malformation?
Something wrong with
The heart?
It's actually an arterial venous malformation. So you end up getting an artery and a vein that are kind of joined together. And so you end up with not only weak blood vessels, but you also have a disruption in blood flow normally. This is something that's congenital. You have to know about it. The only way that they really can find out about these AV malformations is they do a CT scan with contrast, and they actually look at the blood vessels of the brain. Otherwise, this can go undiagnosed until they end up having some sort of a stroke. And generally, they'll find these during autopsy. So it's something that we all probably have. That's that ticking time bomb that a lot of people, you'll hear on TV. But unless they know about it, this has to be a known AV malformation.
That'd be like a fistula type of thing, or just
I guess you can kind of equate it to like a fistula.
like those wires, they're like leaking in.
Now you're just overthinking. And then no history of recent seizure. The idea is that the seizure because they increase high CP, which would indicate more of a stroke. So this is what doctors are going to use to initially determine whether or not TPA is even possible. Then they're going to do a CAT scan to look for occult blood within the brain tissue. If all of this comes back within limits, then they're going to go ahead and administer TPA. As long as, the other thing I would throw on here is within 3 to 3.5 hours is the onset. Okay, so that's going to be your checklist on that.
Is there a number for freestanding seizure activity? As in past hour or past day?
I would say that led up to the signs and symptoms. Again, this is just a checklist. It's nothing that we're going to utilize, but within the Los Angeles Pre-Hospital Stroke Scale, they also have a large checklist that they have to go do. Basically, what they're doing is they're doing the history work for the facility so they can handle the checklist, and it saves them from having to go through and spend 5 or 10 minutes doing the checklist because you've already done it. So it helps to speed up time at the end so that they can get them into that definitive treatment and determine whether or not TPA is going to be a viable treatment for them. All right, so kind of a recap. What are our two types of strokes?
Hemorrhagic and distress.
Okay. What is the difference in signs and symptoms between a hemorrhagic stroke and an ischemic stroke? If you had to pick one sign, the ICP, which we're going to see through blood pressure, right? These are going to be your hypertensive patients.
Dilated pupils.
Exactly. And they're going to have dilated pupil. Remember, that's always going to be a late sign, so don't rule out the possibility of stroke just because their pupils are equal, round, and reactive.
Wouldn't you get a increase in blood pressure and then a ischemic stroke too, though?
You can, but it's not as profound. You have to look at the exact pathophysiology of what's going on. If that stroke happens to be in that brainstem portion that's controlling blood pressure, absolutely. That's why it's not conclusive for us in the field to determine that. But the majority of time, any patient that we see that's profoundly hypertensive, you can expect them to be having a hemorrhagic stroke. Again, is our treatment any different though? Treatment's going to be exactly the same. In that blood pressure, I had a thought, completely forgot where I was going with it. Yeah, so the biggest thing between our ischemic strokes and our hemorrhagic strokes, you're going to see that blood pressure. What also is their main complaint in a hemorrhagic stroke? Worst headache of their life, okay? That's what they're going to tell you. They're going to say, I've had this headache, it's killing me. Literally, it probably is. So those are going to be your big differentials between the two. Again, our treatment's going to be the same. ABCs, prepare to suction, have benzos ready, possibly intubation. Try to elevate their head, and you're going to rapid transport to the nearest stroke facility. All right, so with that, we've got something called